mahalaga. Ito'y handog nating mangaratek sa bansang Pilipinas, nating sinisinta. Si Rowan Jen, ama ng aming propesyon, liwanag na hatid, dala niya ay pag-asa. Ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila, tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mangaratek sa bansang Pilipinas, nating sinisinta. Isigaw at magsaya, mangaradtek ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunyi natin sa mundo. Ipagpunyi natin sa mundo.
Good day, everyone. We are on the third online continuing professional development platform for Asian Radiologic Technologists Societies. Hosting now is the Philippine Association of Radiologic Technologists, PART Philippines. I am Peachy Luna, your program moderator. Ladies and gentlemen, to give their short message, let us all welcome the presidents of the different RT societies and associations. Let me start with the president of the Philippine Association of Radiologic Technologists. May I have the honor to read to you the message of the PART president. President Rolando Bernares is grateful to all the society presidents for the great idea of creating an online activity amidst the pandemic. With these challenging times, the societies of RTs had the common goal to continue providing support to the radiographers and radiologic technologists working as frontliners to continue developing their competence and meet the quality of patient care and provide a high-value impact radiological services. He hopes that we will continue supporting each other's activities and share valuable support to the objectives of all societies of radiologic technologists. Mabuhay. And now, as we continue, let me now call the president of other societies to give their short welcome message. To start, I would like to call Sir President Fernando Koch of the Macau Radiologic Technologies Association. Sir Fernando Koch.
Hello everyone. Good evening. I am Fernando Koch, President of the Macau Radiological Technology Association. Welcome all of you tonight, the third CPD of the Asia. I hope everyone can learn some things and hope all of you to support us. And thank you very much.
Thank you very much, President Fernando Koch of the Macau Radiologic Technologies Association. Next is the President of the Indonesian Society of Radiologic Technologies, President Giek Sugianto. President Giek Sugianto.
Hello. Good evening, everyone, the panelists, speakers, and all audience. I am Giek Sugianto, President of Indonesian Society of Radiographers. I hope everyone is safe and well. Welcome to the third CPD Asia programs. It is great honor for me as a president of PARI to be invited to this event as panelist. On behalf of Indonesian Society of Radiographers, I also would like to say congratulations to PART and team for hosting this event. I know it has been a difficult time for everyone due to the pandemic, but I really appreciate the participation and enthusiasm of all audience to join this event. I hope we can use this opportunity to share knowledge and experience amongst radiographers in ASEAN countries. Thank you and have a nice evening.
Thank you, President Giek Sugianto. Next we have is the President of the Vietnam Association of Radiologic Technologists, President Thai Van Loc.
Good evening, all panelists and audience in Philippines and Indonesia, Myanmar, and Macau, and in Cambodia. Thank you so much. I need to everybody support for Asia CPD continues. I want to share with everybody in May in Macau host Asia CPD Asia CPD in May, and I want to invite everybody in Asia CPD. We please support everybody support for us. We host Southeast Asia and Asia CPD in 27 Sunday June. We will host Southeast Asia I will invite everybody, send abstracts. I will send for everybody information. We will have imaging session. We will have a radiotherapy session. We also will have a nucleic medicine session. We would like to invite all audience send for us abstracts. We will send for your society information more and more about in Southeast Asia. Again, Sunday, 27 June. Thank you so much, everybody. Good health with everybody. Thank you so much.
Thank you very much, President Thai Van Loc. As we all know, the Myanmar is facing a challenge at this point, and so we would like to say to all participants from Myanmar and to President King Mountain that we hope that in the next CPD online platform, we would be able to have you again here in our program. But we are lucky enough, though, that we have Mam Sophic Lee, the president of the Cambodian Association of Radiologic Technologists, to give us also a short message. Mam Sophic Lee.
Okay, thank you so much. Hello everyone, I am the new president of Cambodia Radiology Association Technology. So today, first of all, I would like to say thank you for everyone inviting me enjoy here. So this is the first time I joined, but I feel too much warm welcome from us. So I hope we are still continue like this, even we have the COVID outbreaks, but we still continue have the communication with each other and share the information and learning from each other. So thank you again and again for the Cambodia the chance and opportunity to join for such as this time also. So thank you so much. On behalf of association in Cambodia, we would like to say thank you for all of you for your support from the beginning and until now. Thank you so much.
Thank you very much, Cambodian Association of RT President Mam Sophic Lee. We are very much excited and looking forward to working with you in the upcoming activities of the CPD Asia.
Okay,
So,
thank you
ladies
so
and
much.
gentlemen, thank you, dear presidents. They will again be joining us later in the Q&A session as our panelists. So as we continue now, before we proceed with the lecture presentations, let me give important program reminders. For those who would like to join and watch us, we are live streaming on YouTube. Please search VART on YouTube so you can watch us live. And for those registered participants who are using the IP video talk link, if in case we will be meeting, and unfortunately, hopefully not, some technical glitches, we would like to tell you that you can also connect via YouTube or the Zoom link just to continue with watching of the lecture presentations. Also, after presentations, we will have the Q&A portion. Our two speakers will give time to answer your questions. When you would like to send your questions, please type your name, your hospital affiliation, and to whom do you address your question. So it will be easy for us to direct the question to the speaker. And in case, again, we fail to answer all your questions, we will be glad to answer your questions via email. So now, as we continue, let me introduce to you our first speaker. Our first speaker is Dr. Jose Carlos C. Aguilar. He is a doctor of medicine and passed the PRC Regulation Commission for Registration for Professionals in 2015. He is a radiology diplomate of the Philippine College of Radiology. He is connected with St. Luke's Medical Center Global City to give us a lecture entitled Prostate MRI. Let us all welcome our first speaker, Dr. Jose Carlo Aguilar.
Good day. This is Jose Carlo Aguilar, currently a CT MRI Fellow in St. Luke's Medical Center in Bonifacio Global City. The objectives of my lecture for today is to know basic anatomy of the prostate gland, to know basic patient indication and preparation prior to the procedure, and to discuss the required sequences for proper evaluation using PIRIS version 2.1. Examination of the prostate gland is usually done using a 1.5 Tesla or 3.0 Tesla MRI machine. The difference between the two will include an improved signal-to-noise ratio for the 3.0 Tesla. Newer machines can be conducted with reasonably decent quality even without endorectal coils. However, one should consider the following situations including uni or bilateral hip arthroplasty, MR conditional implants, or devices requiring a lower field strength and extensive tattoos in the pelvic girdle area. In St. Luke's Medical Center, the more common procedure we perform is the multiparametric prostate MRI. This combines anatomic information from T1 and T2 weighted sequences with functional information from diffusion weighted imaging and dynamic contrast enhancement. The main differences of acquiring multiparametric prostate MRI versus biparametric prostate MRI is the presence of contrast sequences in the multiparametric prostate MRI. MRS or MR spectroscopy may also be included as an additional sequence in the multiparametric prostate MRI, but it is not routinely done. If patients are with budget constraints, a biparametric prostate MRI is considered. Prostate MRI indications includes the following: to detect and localize clinically significant prostate cancer in patients with a negative or without a previous biopsy, for active surveillance, prostate cancer staging, and detection of recurrence. Patient preparation will include an interval of more than or equal to 6 weeks in post-biopsy procedures for the prevention of diagnostic compromise due to post-biopsy changes, bowel motion artifact reduction with antispasmodic agents like Buscopan, fasting period of at least 4 hours, and bowel evacuation prior to the procedure. Abstinence from ejaculation of at least 3 days is also recommended for proper distension of the seminal vesicles. However, no clear established benefit is seen. So let's move on to the prostate MRI anatomy. So the ejaculatory ducts ends at the prostatic urethra at the verumontanum. The transition zone surrounds the prostatic urethra. This zone enlarges in aging men, resulting in benign prostatic hyperplasia. The central zone lies behind the transition zone and surrounds the ejaculatory duct. The peripheral zone is the largest area, situated on the posterior and lateral side. The anterior fibromuscular stroma is a thickened area of tissue. It surrounds the base and mid portion of the prostate on the anterior side. So the prostate is divided into the anterior and posterior part. It is divided in the base, the mid portion, and the apex. Each part is subdivided into 12 sectors. It employs 39 sectors, 38 for the prostate, 2 for the seminal vesicles, and 1 for the external urethral sphincter. In our institution, it is important to have lower abdominal sequences, including T1 and T2 weighted sequences, to assess local or distant invasion or metastasis as seen in the slide. It is usually taken above or at the level of the aortic bifurcation. For this particular case in the right, a staging of T4N1-M1B is demonstrated, which shows an enlarged right iliac lymph node and right proximal femur bone metastasis as pointed by the reference arrows. Other helpful sequences are also taken, including axial steer and GRE sequences on the last 2 slides, but these are optional depending on the institution. So let's discuss the multiparametric prostate MRI sequences. The standard DCE or dynamic contrast sequences. We also include the T2 weighted 3D acquisition, which will be discussed later. For T1FS sequences, the purpose of which is for the general overview. It is for the detection of prostatic hemorrhage, pelvic bone and soft tissue characterization, and assessment of lymph nodes. It is taken in axial plane, and slice thickness and in plane resolution may be increased for increased anatomic coverage. So the T2 weighted images are required for glandular morphology. It is also the main sequence for evaluation of the transition zone. Assessment of extraprostatic extension and seminal vesicles are also better seen in this sequence. It is important to take the sequence in all planes, including axial, sagittal, and coronal, with a slice thickness of not more than 3 mm. The DWI-ADC sequence goes hand in hand in assessing for the reflection of random motion of water molecules and adds a key functional component in the depiction of hypercellular tissue, which is highly correlated to malignant cells. It is the main sequence for evaluating the peripheral zone. High B values are necessary to create a high signal-to-noise ratio, and a B value of at least 1,400 is recommended. In this slide, a T2 weighted hypointense lesion was detected and located dorsally in the peripheral zone of the mid portion of the prostate on the right. This is also markedly hypointense on ADC and markedly hyperintense on DWI. The lesion does not abut the pseudocapsule, and there is no sign of extraprostatic growth. PIRADS 5 is the impression with a Gleason score of at least 3+4, which means an intermediate chance for aggressive cancer. In our institution, we take 2 axial sequences of B1000 and B2000 respectively. You can also add oblique sequences if needed. So the dynamic contrast enhancement is needed to improve differentiation of equivocal versus likely malignant peripheral lesions, which increases the PIRADS score if the suspicious lesion enhances. It is also important for evaluating of locoregional recurrence in a post-prostatectomy setting. Injection of contrast of at least 0.1 millimoles per kilogram at 3 ml per second with a temporal resolution of at least less than 15 seconds. So sagittal and coronal planes are also taken for better assessment. So the prostate 3D T2 weighted images are taken for the purpose of glandular morphology and may be taken in axial, coronal, or sagittal views depending on your institution's protocol. So here is the sagittal view. And the coronal view. So moving on. Additional pointers are to use the same examination volumes and angulation for axial T2 weighted, DWI, ADC, and DCE images. Use the same slice thickness for all sequences except 3D imaging, which may be less than 7 millimeters. If possible, calculate high B value in a patient with hip arthroplasty and use metal artifact reduction algorithms if possible. So I'll just show you an example on how we interpret the prostate MRI once images are acquired using these representative images with axial and coronal T2 weighted images on the top and DWI ADC with high B value on the bottom. So what we see here is a T2 ill-defined moderately hypointense expansile lesion in the anterior and posterior peripheral zone base to apex with extension to the right peripheral zone and bilateral transition and central zones. Foci of moderate to marked restricted diffusion are also observed, predominantly in the left peripheral zone base to apex. Eventually, we diagnosed this patient with as PIREDS 5 with extraprostatic extension as well as enlarged lymph node and osseous metastasis. The tumor staging for this was T4N1 M1. So here are my sources, and thank you for your attention.
Thank you very much. Our first speaker, Dr. Jose Carlo Aguilar. So our next speaker is Mr. Anthony Ariola Rodriguez. He is a senior magnetic resonance imaging technologist at St. Luke's Medical Center, Bonifacio Global City, Philippines. He is also a member of PART and other local RT organizations and has made RT researches like in-doc dementia research. Ladies and gentlemen, to give us a presentation on stroke imaging, brain attack protocol in MRI, let us welcome our second speaker, Mr. Anthony Ariola Rodriguez.
Good afternoon, everyone. Today we'll be talking about stroke imaging for brain attack protocol and how important time is for stroke management, and also how CT and MRI plays a big role in stroke imaging. So what is stroke? It's a sudden onset of focal or global neurological deficit due to an underlying vascular pathology. What are its main principles? Stroke is a brain attack. Stroke is an emergency. Stroke is treatable, but more importantly, stroke is preventable. What is the golden hour for stroke? It's 3 to 4.5 hours since the last ictus of the patient, meaning the last time you saw the patient in a normal condition. When do we activate BAT? All adults 19 years old and above who are suspected of having a stroke within 6 hours from the symptoms of onset or within 3.5 hours upon waking up, which means if the
Inasya talaga, no?
suddenly had the symptoms of stroke, the ictus would be the time when the patient woke up.
What scale is used to assess if practitioner observes the signs and symptoms of stroke? Internationally, we use the Cincinnati Pre-Hospital Stroke Scale with the methodology of face, arms, and speech. But here in St. Luke's, we use the B-FAST assessment tool. B for balance. Patient is experiencing loss of balance or probably having the worst headache of their lives. E for eyes. There's blurring of vision. F for face. One side of the face is drooping or asymmetrical. A for arms. Arms and legs are weakened. S for speech, or the patient is experiencing difficulty of speaking or dysphagia. Time. Time to call the ambulance. Always remember, lost time means lost brain.
What are the two types of stroke? Ischemic. Ischemic stroke occurs when there's a blockage of blood vessels in the brain. This accounts to 70% of cases of stroke. The blood flow is blocked and brain area is deprived of the blood supply. There are two types of ischemic stroke: the thrombosis and embolism. Thrombosis: blood clots that form in the blood vessels of the brain. Embolism: blood clot is formed from another location, usually from the heart. Another type of stroke is the hemorrhagic. Hemorrhagic stroke is bleeding within the tissues and spaces around the brain brought about by a rupture of blood vessels. This accounts to 30% of cases of the brain attack. And there are two types of hemorrhagic stroke: the intracerebral and subarachnoid hemorrhage. Intracerebral are types of hemorrhagic stroke that is presence of blood within the tissues of the brain, usually caused by uncontrolled hypertension. Subarachnoid hemorrhage, a type of hemorrhagic stroke where blood spills around the coverings of the brain and called subarachnoid spaces. This is usually caused by a ruptured aneurysm. For ischemic stroke, it is preferred to do the imaging in MRI, and for hemorrhagic stroke, it is preferred to use the CT scan imaging. What is thrombolysis? RTPA or Actalis. RTPA stands for recombinant tissue plasminogen activator. It is a fast-dissolving drug which can potentially reverse the signs and symptoms of stroke. It should be given within an hour in the wartime. And doses is given to any eligible ischemic stroke patients evaluated by the stroke team who meets the strict criteria for administration. What are the contraindications for this drug? Number one would be the advanced age, severe hypertension, rapidly improving or minor symptoms, seizure onset, severe stroke, recent myocardial infarction with diabetes mellitus, CNS pathology, brain neoplasm, antivenous malformation, or uninterrupted intracranial aneurysm. If there is recent GI bleeding or any recent major surgery. The timeline that we use is the National Institute of Neurological Disorder and Stroke Timelines bat response time. Here's our table. Door to doctor first position and brain attack activation would take about 10 minutes. Door time to stroke team, meaning upon the activation, the stroke team has 5 minutes to be able to assess whether the patient is ischemic or a hemorrhagic infarct patient. Door time to neuroimaging initiation, whether the patient will be going to CT or MRI, they have 10 minutes. Now, door time to neuroimaging done and read, meaning CT and MR has 20 minutes to be able to complete the scanning and have an initial reading. In an event, we have a procedure of RTPA, or the patient has a ischemic infarct and a candidate for RTPA. Door time to needle would be 60 minutes, meaning they have 15 minutes to do so. Now, door time to neurosurgery, they have an R, meaning from the door time or from the patient from the time the patient arrives from ER, it would take us about 2 hours, and by 2 hours, the surgery should have been started or should have already been done. Now, door time to the monitored bed, ASU, NCCU, or 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 cath lab would take about 3 hours. Who are the members of the brain attack team? They are subdivided into 3 groups: the medical practitioner on duty, paramedical associates on duty, nursing associates on duty. For the medical practitioners on duty, they are namely neurology, neurosurgery stroke consultant, neurology and neurosurgery resident, medical resident, emergency care service consultant, radiology consultant, clinical pathologist, and endovascular specialist. For the paramedical associates on duty, they are namely clinical pharmacist, medical technologist, radiologic technologist, and for the nursing associates on duty, they are namely emergency care service nurse, bedside nurse, stroke nurse, house manager, cath lab nurse, nursing assistant, and patient care assistive personnel.
Our MRI machine here in St. Luke's are the Philips Achieva 1.5 Tesla, Philips Achieva 3 Tesla, Philips Ingenia 1.5 Tesla. But due to the pandemic of COVID-19, we designated that the Philips Ingenia 1.5 Tesla would be the one to be used during BAT patients. MRI stroke protocol or MRI BAT protocol can be done within 20 minutes. It is composed of diffusion weighted image or DWI and apparent diffusion coefficient or ADC. DWI and ADC provides an image contrast that is dependent on molecular motion of water, and its most sensitive method to date for the depiction of ischemia in the hyperacute stage. But it should be remembered that DWI lesions can be at least partially reversible in the very early phase of ischemia, and the size of DWI abnormality does not necessarily reflect the irreversible damage of tissue. T2 and fluid attenuated inversion recovery or FLAIR. On T2 and FLAIR images, ischemic infarction appears as hyperintense lesion, usually seen within the first 3 to 8 hours after the stroke onset. In a recent study of acute ischemic stroke patients, studied by the MRI within 6 hours of symptoms onset, patients without a visible hyperintense lesions on FLAIR images had a greater 90% probability of being imaged within the first 3 hours of symptoms of onset. Thus, a mismatch between the positive DWI and negative FLAIR appears to be useful in identification of the patients who are likely to benefit from thrombolysis. Also, FLAIR images are also sensitive for subarachnoid hemorrhage, as well as cerebral venous sinus thrombosis. For the gradient recoil echo or GRE, hyperacute stroke images demands a differentiation between ischemic and hemorrhagic stroke. Moreover, microbleeds can be seen not apparent on CT. It can also detect the interluminal thrombosis or thrombus, a linear low signal region of magnetic susceptibility. For actual TOF, or time of flight, this sequence depicts vascular flow of repeatedly applying radiofrequency pulse to a volume of tissue, followed by defacing and refacing gradients stationary to tissue in the volume that becomes saturated by the repeated excitation of pulses and has a relatively low signal. Conversely, inflowing blood protons are not saturated and therefore produce relatively increase in signal intensity. 3D TOF MRA are preferred techniques for examination of intracranial vessels. MRA is particularly useful in detection of the vascular occlusion or stenosis in patients with ischemic stroke.
This is an example of hyperacute hemorrhage. Patient was brought to ER at 11:36 a.m. or our door time. The ictus of the patient is 11 a.m. with a history of progressive right-sided and upper-lower extremity weakness with slurring of speech or the patient is aphasic. Actual MR images shows a hyperacute hemorrhage in the left lentiform nucleus and a mass-like effect adjacent to the suicide body and the left ventricle and with a mild perilesional edema. For T2 and flare signal, hyperintensities are appreciated in deep white matter regions, with both cerebral hemispheres may relate to microvascular or ischemic demyelination or gliosis. Mild cerebral volume loss, there is no aneurysm or stenosis found.
Axial T1 spin echo shows an isointense and hypointense in the left lentiform nucleus, with a mass-like effect adjacent to the sulci body, left ventricle, and insula. For GRE susceptibility imaging shows that susceptibility appearing at a low signal intensity due to blood deep white matter, both cerebral hemisphere, which may relate to microvascular cerebral ischemia demyelination or gliosis. For axial CT scan imaging, a hyperdense hemorrhagic collection with associated perilesional edema in the left lentiform nucleus is again noted, with a volume of 23.2 cc by CT volumetry.
For time of flight, there is no aneurysm seen in the circle of release. The A1 segment of the left anterior cerebral artery is dominant. The middle cerebral arteries or distal branches are patent and normal. The intracranial and extracranial internal carotid arteries are normal. The vertebral basilar arteries are unremarkable. There is no displacement of the vessels.
For an example of an acute infarct, a 60-year-old male came to ER at 9 a.m. The ictus time was 5 a.m. Patient's history is right-sided weakness, shallow right basalopial fold, and dysarthria. Non-contrast MR study of the brain or the brain attack protocol with intra and extracranial angiography multiplanar views was done in 1.5 Tesla Ingenia. Foci of restricted diffusion and corresponding flare signals is identified in the left lentiform nucleus, reflective of acute infarction. There is no demonstration of intracranial hemorrhage or mass lesion. Minimal cerebral loss volume is noted. The ventricles are not dilated, midline structures are in place, and the cisterns and sulci are effaced. For the gradient record echo, there are no intracranial hemorrhage or mass lesion. Chronic blood products are in normal brain tissue. There are no visible cerebral microbleeds. And for the plain time of flight angiography, there are no focal aneurysm. The proximal cerebral arteries are adequately visualized. Intra and extracranial internal carotid arteries are in normal. The vertebral and the basilar arteries are unremarkable. There is no displacement of the vessel. For hyperacute infarct, candidate for RTPA, patient is 52 male, came to ER about 3:35 p.m. The time of ictus was 2:50 p.m. Patient history is asymmetrical lip, slurred speech, loss of consciousness. Non-contrast MRI study of the brain attack protocol, with intracranial and extracranial angiography in multiplanar views was done in 1.5 Ingenia. DWI sequence shows that there's a foci-restricted diffusion in the left parietal and temporal lobes of the insula, left middle cerebral artery territory, without corresponding flare, hyperintensities relating to hyperacute infarct. During the GRA sequence, there are no intracranial hemorrhage or discrete mass lesions found. For the actual time of flight, There's a signal attenuation involving the distal M1 segment of the left middle cerebral artery. Contour irregularities are present in both internal carotid and vertebral arteries relating to arteriosclerosis. The rest of the proximal cerebral arteries are adequate and visualized without evidence of any significant stenosis.
Due to COVID-19 pandemic, treating brain attack patients were modified. All BAT and non-BAT patients are treated as a possible COVID-19 cases. All responders must wear appropriate PPEs as recommended by the Infection Control Services. All patients must be transported with full precautions. Unit-based precautionary measure must be respected. Proper coordination between units prior to transfer in order to prepare the receiving unit. All stroke patients for admission must have a routine nasal and oropharyngeal COVID-19 PCR rapid swab for screening. COVID probable suspect confirmed patients will be admitted at the COVID isolation room, ICU, even while waiting for COVID-19 PCR rapid swab result. Once negative, they will be moved to non-COVID units. For my references, I would like to acknowledge St. Luke's Medical Center Stroke Unit, or the BAT team, St. Luke's Medical Center Radiology Department, and the American Stroke Association. Thank you everyone for spending a little bit of your time listening, and everyone have a great day.
Thank you very much to our second speaker, Sir Anthony Rodriguez. You can now open your camera, dear speakers, as we would like to welcome the questions typed in through the live YouTube streaming and from the IP video talk from our registered participants. So I think we have questions here to our speakers. Panelists can also help me out in delivering the questions from our dear participants. If you'd like to read one.
I have a question.
Yes.
Yeah. Good evening, Putu from Indonesia. Good evening. This is my
Good evening.
sister. My sister.
Yeah, Miss Putu, please.
Yes.
Miss Putu, please.
Yes.
Yeah, you can comment maybe.
Good evening.
Miss Putu.
Yeah, good evening.
Yeah.
Okay.
Yep.
I see have a lot of questions for two doctor, yeah, two speaker. But I have a question. I think you will ask for question for Dr. Tony. I have a question for Tony. I'm worried. I'm worried. How about in your center now?
Okay.
How about in patient stroke patient? You know I understand in goal time very important. Yes, we select the city first or your center. You choose MRI. I think you speak you tell in MRI in all protocol in 20 minutes. I think okay, good. But you remember very important also in your center. In your center, we select in the first city first, or you choose direct MRI. The first question. The second question, or COVID-19. The second question. In COVID-19, you see you have 19 patients in SARS-CoV-2 positive. Oh, very special. If have a time, you can share for everybody. Patient stroke and to get positive in SARS-CoV-2. Very important how you can share your experience for everybody. I think the second question you answered late. If have a free time for you. Okay, thank you so much.
Sir Anthony, did you get the questions from Sir Taiwan Locke? I think he is asking about whether in your center, it's the CT that is first requested for a stroke case, or since you have a 20-minute MRI scan only. And
Okay.
I think second question is about if you can share more about how you do stroke imaging using MRI for COVID cases, COVID patients.
Okay. Here in our institution, we treat all BAT patients or stroke patients or the brain attack patients as a COVID patient. So once we are alerted that there's a BAT patient, we treat them as PUIs or PUM, and we need to have a, what they call this, we need to wear our PPEs, our proper PPEs, and our machine is as I have said on my slide, that we're using the Wi-Fi 5 Tesla Ingenia, which is separated from the other two machines. So we could be able to contain the bad patients and avoid the spread of COVID-19. For the question, is it MRI the one that's being used immediately or is CT? It depends. Clinically, the doctor or the neurologist would be the one who's going to assess it. If the clinically they see it as a bleed or a hemorrhagic patient, or the patient has had a intracranial bleed, they would directly go to CT scan. And if it is a ischemic infarct, then they're going to decide to go to MRI. That's it.
Sorry, I'm worried. How patient don't move for you in 20 minutes? You check your protocol MRI. I'm worried.
You're worried. You
Yes.
don't believe. You don't think that it's going to be 20 minutes. It's going to be 20 minutes. Yeah.
No?
Yes. Okay. It's going to be 20 minutes because our actual T2, we do have a fast protocol for T2. We have a fast protocol for flare. For T2, we can do it if in case we need to do it fast. There's a fast protocol for Philips, which is about 58 seconds. Okay. For flare, there's 1 minute and 36 seconds. For GRE, it's 1 minute and 50 seconds. For DWI, it's just 30 seconds, and together with the EDC. And for TOF, that's just 3 minutes and 3 minutes and I think it's 50 seconds for the intracranial, and for the 3 minutes for intracranial, 3 minutes for extracranial. So basically, we can be able to do it that quick.
Thank you. Yeah,
Okay.
a lot of questions.
Okay.
In chat box. Yeah.
Yeah, I think there is a relative question to what Sir Anthony Rodriguez has just said. There's a question from Henry Pura White. The question is, are they enough for 20 minutes to finish MRI BAT, including axial TQF? Can you share the tricks to make it done on 20 minutes, and why you didn't do a sagittal and coronal?
Okay, because of the time constraint, we cannot do all the sequences, the sagittal and coronal. The purpose of BAT being catered to a very few protocols is one, so that we can be able to assess if it is a hyperacute infarct. Okay, that's very important for MRI because of the RTPA. Okay, and if you're going to ask me how to do it fast in TOF, it takes a lot of years of experience to be able to do so. So if in case I have a patient that is normal, I do try to run some very few protocols for that. But the number one trick for that is you could be able to, we do have, what they call this? the pulse tone. We're using the pulse tone. I'm using the combination of sense, charm, and also the combination for with the proper combination of the voxel acquisition and the proper matrix. Because if you're not going to be able to use the proper matrix for that, you're gonna miss out the occlusion on the vessels. It's very important. And most of the time, I try to use ResLab or pre-saturation so that we could be able to avoid unwanted artifacts on the vessels. Yes.
Yes, thank you, Sir Anthony.
Okay.
Again, the cam is open for your questions to our speakers, dear panelists. If you have any, just give me a cue so I can allow you to deliver the question to the speaker. Yes, President Sugianto from Pali, Indonesia.
Hello, good evening, the speakers, and also Hin, President Hin. Hello. Yeah, hope you safe in your country. Maybe Putu Irma, you can have a question, please.
Thank you, Mr. Sugianto. Thank you, Pichi. If you allow me, I want to add some points or add some questions to the presenter. Okay, thank you. Actually, initially I thought the same as Mr. Locke, that I always thought that CT scan would be the first choice for stroke imaging because time is very critical and we can do it very fast on CT to distinguish whether the patient has stroke, ischemic or hemorrhagic. But it is great to know the practice in different countries that Mr. Anthony can do the MRI scan for 20 minutes for certain cases. And that's my points. And actually, I have a questions to Dr. Jose Carlo, maybe? Yeah, so I want to ask your opinion about what is the role of prostate spectroscopy while the latest PIRADS guidelines no more using spectroscopy. And the second question is regarding the sequence that you use for the MRI. What's the best sequence that we can use to distinguish the malignant or benign tumor? Thank you.
Okay, thank you so much for that question. For the MRS or the spectroscopy, we usually don't employ it anymore. It's just for the like the study in the brain, like lactate peak or the ratio for creatinine and stuff. It's not usually done anymore. So what we usually do is just the multiparametric prostate, since it's already enough to say if the lesion is on what PIRAD score. And then after that, for added learning, the PIRAD score, if it's more than 4 or 5, we usually refer them for targeted biopsy. And we do this also in our center with the guidance of ultrasound. For the second question, what was your second question again? I'm sorry.
Hello.
Hello?
Putu?
Yeah, I think the second question is about what is the best choice for the sequence to differentiate benign or malignant, I think. Yeah.
Okay. Thank you. Thank you so much for that question. For malignant focus in prostate MRI, I think the best sequence would be, it depends on what location. So as I said earlier, when you're looking at the peripheral zone, you need to look at the DWI ADC maps. But when it comes to the transition zone, you need to look at the T2 weighted images. So it's better, or because of the glandular morphology of the prostate gland, some areas are more susceptible for proper distinguishing of what type of lesion it is. So I cannot say which sequence would be the best to assess uh, for the malignancy, but it usually helps us in radiology to get all the sequences together for a better interpretation. Thank you.
Thank you.
Thank you, Irma.
Yes.
Is there any other question from the panel? While you are preparing your questions, maybe, so I'd like to read a series of questions here. I think this is for Dr. Aguilar. Question is it necessary to acquire lower abdomen post-contrast images? Is it also advisable to do a non-contrast multiparametric prostate? Do you have an ideal time to complete a prostate MRI? And what can you say about contraindications for patients who have polycatheter?
Okay. For the first question, it's the sweet. Do we need a lower abdomen sequence for post contrast? It depends, because usually when we see some enhancement, some enhancement may delay on the post contrast images, but on our protocol, we just take the pre contrast lower abdomen sequence to check for enlarged lymph nodes. And for metastasis on the bones. This is done for different reasons, because it may depend on the surgeon on what management they will take. For example, if you stage the tumor or the prostate cancer with metastasis to the iliac bifurcation, there will be a different management for this. It's usually the radiotherapy first before the surgery, because they need that to happen. Second question again, ma'am, can you repeat?
Second question is it advisable to do a non-contrast multiparametric prostate?
Uh, it depends on the patient. If there is he has budget or budget constraints, and usually in our institution we just go to the multiparametric prostate MRI, which is the included contrast. If you're talking about non-contrast MRI study, it should be biparametric prostate MRI. It's not multiparametric.
Yeah.
What's the third question?
The third question, sorry for this series of questions, Doc. This came from one single person only. So what is the ideal time to complete a prostate MRI? Do you have an ideal time to complete
Ideal
one?
time, well, in St. Luke's, it takes about 1 hour and 10 minutes, I think. I don't know with the red text, but for the 3.0 and 1.5 Tesla, they say it's usually 1 hour and 10 minutes. So maybe that's the ideal time.
And the last question from Shan is there, what can you say about the contraindications for patients who have Foley catheter?
Foley catheter. There's no publication regarding the contraindication for Foley catheter. I think there's another question that is asking if we should empty the urinary bladder before the procedure. It would be wise if you do not empty it, because we also need to assess, as radiologists, we also need to assess the urinary bladder if there is extension of mass within the urinary bladder. And one best contrast to use for it is fluid. And you can see different masses if there are any. For Foley catheter, I haven't encountered or haven't read any journal regarding using it for the scan. So I think it's okay. It doesn't affect the quality. Just don't have any air within the Foley catheter, which is very important.
Dear panelists, would you like to help me read some questions posted over the chat box? Sir Kin Mounting, welcome. We are glad that you are
Yes.
now here.
Yeah. Yes. Hi, Pichi, and
Yes.
everybody. Please excuse me because of the very weak internet, and I can just sign in just now, so I miss all the speakers' presentation. But anyway, I can listen with the YouTube again. Okay.
Yes, thank you, Sir Kin Mountain, President Kin Mountain. Please do tell your members that they can still access the VART YouTube channel and watch,
Yes, because
watch this later.
you know they are very busy at the
Yeah, I
moment.
know. Yes.
uh, the,
So yeah, so I'd like to read some more questions here posted on the YouTube, the Zoom chat box. So the question here is from Frank Pandapotan. Is it correct? Lokot. The question is, in the head examination in MRI, I think this is for Sir Anthony, can we see more extensive bleeding as a whole?
Come again, Ma'am Peach. Sorry, I
The
didn't
question,
catch
yeah,
them.
the question here of Mr. Locott is, in the head exam of the MRI, can we see more extensive bleeding as a whole?
Extensive bleeding. When it comes to bleeding, there are a lot of sequences that we can use. GRE is often used for BAT, but but due to the constraint of 20 minutes, we cannot do the SWI, which is more in-depth analysis for the blood or for the bleeding. But we can be able to see it. We can be able to see bleedings in GRE, but we cannot grade it that much. We need to use the SWI or susceptibility weighted image. It could be done after the analysis of BAT. Maybe in St. Luke's we do the completion scan. We do the completion scans. Maybe we can do the SWI after the completion scan. That's it, Ma'am Peach. Sorry, Ma'am Peach, we cannot hear you.
To our dear speakers, I hope you can also read the questions. There are so many questions posted on the Zoom chat box. You can choose to answer because of the limited time that we have. So maybe you can help me read questions which you think is the best to discuss here with our limit of time. So while you are trying to pick some more important questions here, I'd like to read one. So here is the question for imaging of the prostate. So this is for Dr. Aguilar. Oh, sorry, to Sir Anthony. Sir Anthony from Mr. John Mark. His question is, can you tell about limitation of FLAIR MR imaging in dating acute ischemic stroke?
Limitation.
Have you experienced?
So far, I didn't have any experience in the limitation of FLAIR imaging in acute infarct because FLAIR and T2 imaging is being used just to be able to assess. Usually, if you're going to do the BAT for the hyperacute infarct, it's just for the comparison for the DWI images. Because if we're going to use the because in DWI, hyperacute infarcts are very hyper intense, and on ADC that's hypo intense. So BAT is being activated so that we could be able to see if we can be able to salvage some part of the brain during the stroke. So actual T2 and FLAIR are used just to compare if in case that we could be able to do the RTPA within an hour. So most likely, for bleeding, we cannot, for bleeding, it's not that very sufficient, as I have said a while ago, to be able to grade it or to be able to know the extent for that bleeding. We need to use the SWI. And sometimes, maybe for this year, they're going to try to include also the perfusion weighted image, but due to the time constraint, they're still asking us if we can be able to do it within, we could be able to squeeze that protocol in the batch sequences. But I think it would not be possible to do it with 20 minutes because of the preparation for the injection, preparation for the patient, and most of the patients are very involuntary when we do that, when we do the imaging. We still that's it. We just need to do the SWI to be able to grade the bleeding for the brain.
Thank you, Sir Anthony. Another question here, this goes for Dr. Aguilar. Dr. Aguilar, this question from John Karait. He asked of the B values that you use for DWI for prostate.
Okay. So the B values that we use currently, since the guideline is 1,400, we currently use the B1000 and B2000. Why is that so? Because for it's in the system. And if I can suggest, I mean, we should do the 1,400 because that's part of the protocol. I think this is done in our 1.5 machine, but in our 3 Tesla machine, it's not yet calibrated. That's why I showed you B1000 and B2000 image. B2000 image is done for detection of smaller lesions. It actually enhances, or it's actually hyper intense on smaller lesions. And you must be careful to compute for the B value because it has the diffusion cortosis effect. So it goes into a much grainier side if you increase the B value. Okay, thank you.
Thank you so much, Dr. Aguilar. Sir Anthony Rodriguez, I think you can read the chat box here in our Zoom link. There's this question, but you please help me interpret his question. This is about MRI of the brain, and I think that the Saya Ful Amin would like to know more about how you do it with COVID-19 patient cases. Can you share more about how you do MRI of the brain with COVID-19 patients?
Most likely we do it. We wear PPEs, and here in our institution we do have, if the patient is really a COVID positive patient, most likely they have ventilators. So we do have a portable ventilators that's MRI compatible. So that's why we can be able to do the MRI also, even if they have ventilators. As I have understand, there's also a question if we could be able to see COVID-19 in MRI brain. Actually, it's most likely, it's just the effect that we could be able to see. For example, if the patient has a difficulty of breathing and has a hypoxia, of course, the brain will get affected, but we need to do perfusion for that so that we can be able to see for the extent of hypoxia. That's the only thing. But there's no journal for anything that we could be able to see. We could be able to see the COVID-19 on brain. So it's just the effect that we can be able to see on the brain for the brain imaging of MRI.
Thank you, Sir Anthony. There's another question from Sean Colleen. Her question is, if 2 bat code is activated, who will be the one who should be done first? Is it possible for stroke patients with orthodontic braces to do also an MRI?
Okay, for the first question, if there are two bad patients that are being activated before a few years back, the neurologist would be the one to assess which is the one to be done in MRI, or if in case we can do the other one in CT scan. But now, if that is the case, and upon assessment of the neurologist or the neuro resident, we can do it also in 3-test lab. But the problem for that is we need to sanitize or we need to disinfect also the other machine for that, if we're going to do that. So I think this rarely happens, but it's the call of the neurologist which one would be the one to be done first. And for the stroke patients with orthodontic braces to do MRI, of course, as we all know, DWI is very important for BAT. So we need to send out the patient to CT scan. Maybe so that they could be able to see it, maybe they could be able to see it. Even if there's a strict artifact, they could be able to assess it. But as we all know, DWI is the superior one to see the ischemic infarct. But if in case upon clinically they could be able to see it, that it could be in the upper part of the brain, or in the cerebrum, or in the midbrain, they could be able to try to, if they cannot see anything on in CT scan, they could send it out to MRI and try to see it in the WI. In DWI and for T2 and FLAIR imaging. But that rarely happens because it's our protocol that if there are braces, we need to do it immediately to CT scan so that we could be able to assess it immediately.
Yeah, very well said, Sir Anthony Rodriguez.
Okay.
So, can you see more questions that you think need our time for answering here from the chat?
Sorry.
Yes,
I
sir.
recommend.
President
I
Taiwan
have
Lok.
recommend for everybody. In COVID-19, you remember because and last time we have many online COVID-19. If the patient SARS-CoV-2, if patient have SARS-CoV-2 in positive, you remember we choose MRI or CT scan very important, necessary. We need to discuss with doctor, a neurology, doctor emergency, ICU. We discuss. Be careful. All the way discuss. I have a recommend for everybody. Yes. I think that we need to discuss with radiologists, radiology and emergency before patient examine MRI or CT. Very important. If patient SARS-CoV-2 positive, and I want to talk with everybody today. A lot of questions for everybody. I think everybody in Philippines, Indonesia. I think the necessary we continue Asia CPD. I want to tell with everybody in May this May continue with Asia CPD in Macau. I hope all everybody support join with us. And very important, in 27 Sunday June, Vietnam hosts Southeast Asia for also online. The same today. I would like to invite everybody in Philippines, Indonesia, Myanmar, and Macau in Cambodia support for us for a lot, many presentation for us. I understand very important, very difficult for us when we organize the Southeast Asia for it online. But I think that everybody can support for us. Thank you so much. Thank you.
Thank you so much, President Thai Van Lock. So our time schedule we will be very glad to answer questions that have arisen from the YouTube and from the IP video talk via email. But as we continue, sadly, we will have to proceed with the closing session of today's program. So I would like to share now the certificates that will be received by our participants. If you manage to complete attending the program, you'll be able to receive via your email address the certificate of completion. We are very much grateful for your participation, and we look forward to having you again in the next CPD Asia conference. We would like to say thank you to our dear panelists, President Rolando Banares, President Fernando Koch. Now we have Sir Pedro Lay from Macau, MRTA. Thank you so much, Sir Pedro Lay. Thank you so much, President Giek Sugianto. Thank you so much, President King Mountain. We are so much happy to have you, even as we know that you have a challenge in your country right now. We hope you well. And President Thai Van Lock. Thank you to our dear panelists. Most especially, we would like to say thank you to our dear speakers. Please receive the electronic certificate of appreciation from the CPD Asia, Radiologic Technology Associations and Societies. Sir Anthony A. Rodriguez, thank you very much for your outstanding presentation. And we also would like to give the electronic certificate to Dr. Jose Carlos C. Aguilar. Thank you so much, Dr. Aguilar, for your time. I know you are very busy. I think you are in the hospital right now. Are you, sir, dear Dr. Jose? Are you in the hospital?
Yes, I'm currently in the hospital.
So we are so thankful that you were able to join us. So thank you again, dear sir. We will meet again, surely, in the Philippines after COVID-19.
Thank you.
So with that, I would like also to acknowledge the help of the VT Healthcare IT team. We are very helpful for the help and all the technical support from the VT Healthcare IT team. We also would like to acknowledge the support of the chairman of the radiology section of St. Luke's Medical Center Global City and Quezon City in the name of Chairman Dr. Nelson V. Pasha. We are very much thankful to all the participants who have registered and participated in the third online CPD program. So again, to Sir Marco Lam and Sir Lee Tan Trong for the technical support, to all the society presidents from the MRTA party, part MS, MRT and VART, and to Madam Sophie Lee of Cambodian Association of Radiologic Technologies, to everyone who has participated and made this third online CPD platform a success. We hope to meet you all again and support the fourth online CPD platform for Asian Radtech societies. Thank you and good night, everyone. Maraming salamat po.
Thank you. Good success, Beijing. Thank you.
Thank you.
For everyone.
Thank you.
Terima kasih.
Terima kasih.
Thank
Salamat
you.
po. Thank you, Dr. Aguilar. Thank you, Sir Anthony. Thank you, Sir King Mountain.
Thank you very much.
Thank you.
Ming Laba, thank you.
Salamat po.
Take care.
Take care, Mr. Tin.
Yeah, hello, thank
Yeah,
you,
brother.
Putu.
Brother.
Ima,
Yeah.
how are you?
Great. Thank you.
Good. Hello, brother Thai,
Yes.
Landlock.
Yes.
You're
Okay.
doing so hard, yeah?
Yes.
Yeah. I'm sorry, I can't, this time, I couldn't give you all my assistant. My situation,
Yeah.
this is lucky because
Yes. You take care.
I can sign in time.
Yes.
But I missed the presentations. But anyway, I can see from the
YouTube.
YouTube.
Yeah. Yeah.
Pichi, sorry. No, I can't give you my hearty assistant to you.
Yes.